Welcome back to day 2. I'm going to be talking to you about a study that we're doing in York Region Paramedic Services, which is just north of Toronto in Ontario here in Canada. The study that we're working on is called Improving Patient Access, Care, and Transportation. As I mentioned, as Gary mentioned, my name is Walter Tavares, paramedic with York Region Paramedic Services, and also a scientist with them, as well as McMaster University. A couple other people I'll just mention very quickly that are on our team: Ian Drennan, who isn't here, Mike Avenel, Chris Spearin, who is, Dr. Van Diepen, Kelly Van Diepen, Dr. Mercury, and Norm Barrett, who are also involved in this study. So I have no conflicts of interest to disclose, I should share, and also the REB for this particular study was provided by these organizations, so McMaster University being the academic institution, and then these are the 3 hospitals that we worked with, and so we required REB from each of them, which I'll explain here in just a second. And of course, the study was provided or supported by York Region Paramedic Services to do this work. So I'm going to start with this idea that I think everyone in the room can appreciate, and that's this tension between increasing healthcare needs and availability of services. And so you can imagine that exists in a number of different places. It might be, for example, in access to specialty services, for example. Or it might be in access to certain procedures. Or even long-term care. If you're waiting for long-term care, for example, and you might have a 6 or 8 month wait here in Canada for long-term care services. The point is that there's this big discrepancy at times between these increasing healthcare needs, which comes from an aging and growing population who's living longer and living with more comorbidities, and the services. And so we have to try to find a way to deal with this particular issue. And I'm sure you can come up with other examples, and I know that this group is well informed on this discrepancy or this tension that exists between these 2 issues. One of the places that gets addressed or gets a bit of focus in the literature is in ED use or misuse. And I don't want to make this necessarily about ED use or misuse, but it serves as a nice example of this problem that exists between healthcare needs and what people are looking for in terms of availability. And so when they study ED use and misuse, whether or not it's being misused, they look at things like reliance. So the public has become increasingly reliant on the ED services. This is usually, or this is an indicator of their success, even as long as, or as recent as 10 years ago, the numbers have increased substantially in this time. Availability of other resources like primary care or ambulatory care, whether or not those services are available to people as an indicator of use or reliance on ED services, and also as an admission pathway for some of the primary care services. So one of the ways that they try to deal with this stuff is to come up with some strategies to try to deal with this discrepancy between these 2 systems, or these 2 issues, or this tension that I described. And so one is to come up, as an example, to come up with some financial incentives or patient education to get people to know when to use or not use emergency department services. And this, again, this is just an example. And so that might be to reduce misuse. Another might be to increase the availability of primary care or ambulatory care services. There's a very close link between primary care, ambulatory care, and emergency care. And so the idea here is to try to reduce need, and a lot of the projects that we heard about yesterday, I should say, was really working on this issue of reducing need. So that's another area. And the other is this care coordination, and again, this is, I'm telling a group of people who know this in terms of increasing care coordination or managed care is another way to try to promote this idea of integrated care. And so one of the things that happens in some settings is that there's a good feedback system that happens between when a patient visits an emergency department and information that funnels back to their primary care physician. So again, there's a nice relationship between those 2. And so looking at it this way, you might say that there's this public use, and this is, I'm thinking about 911 access or patients who access services themselves, who make those decisions themselves in terms of when they need it and when they don't need it. And so there's this issue of public use and need, and misuse as well. And so the emergency department and primary care, ambulatory care settings, good relationship between those 2 in terms of studying this tension that I described right at the beginning. So thinking of a larger healthcare system issue. And so another thing that we could add, obviously in this group, is paramedic services. But if I wasn't speaking to a paramedic group, I would say increasing or adding other services or shifting services is something we should consider on a healthcare system issue. So not just paramedic services, but anything else that you can think of. And so that should be the creative thinking. It should be, how do we establish a nice integrated relationship between these 3 areas as an example of improving healthcare system issues, promoting healthcare in our areas. And so it got us thinking about whether or not we're contributing to the problem or we're really working towards mitigating the problem. So again, the problem being this tension that exists between what patients need and want and availability of services. And so in our area in Ontario, Canada, when patients initiate their care or their services, whether they're right or wrong, when they initiate it, paramedics are almost obligated, as we heard yesterday, to take everyone to an emergency department. And so, so the question comes up, are we contributing to the problem of this access and need issue that I raised? And so, obviously, we're focusing in on the paramedic service, but not as an innovation to the paramedic service, but as an innovation to the healthcare system to see what can be offered there. So, and I should mention that this is a program of research, and what I'm sharing with you today is really just one phase of 5. Phase 2 of 5, and so the idea is to eventually get to this program of eventually get to this place where there's some meaningful integration between these 3 systems here. And so really, we're just focusing at this point between the emergency department and paramedic services. And so our research question was, given all that, we were asking, of patients transported to an ED by paramedic services following 911 activation or 999 or 000, whatever the emergency number is in your area, of patients transported to an ED by paramedic services, what is the course of clinical care disposition and most responsible diagnosis? Again, for those patients who activate the system themselves, 911 systems, that is. And then the second question was, what additional clinical services provided by paramedics in a 911 model or in an emergency care model would result in the greatest access, care, and intelligent transportation of patients encountered during emergent or urgent conditions? And so everyone in here in this room certainly understands that there are a number of low acuity calls that occur. I think we heard yesterday in one of the presentations 80 to 90% of the time. And so, but that is part of a 911 system. And so we want to think about what can we do for that 911 system that might improve this tension that we've been talking about. So another way to think about this is there's not just in paramedic services, but certainly elsewhere, they're talking about how can we shift services to improve capacity in the system, give the overall system capacity by shifting services, not necessarily only to paramedic services, but in a number of different places. And so another way to think about those research questions is to say, how can we shift services to address this tension? And so that's the gist of what we were looking for. And the goal is to eventually work towards that integration of those 3 systems, at least in Ontario for now. So the way we did this was, and again, I'm just sharing one part of the study. One of the ways we did this was a retrospective cross-sectional descriptive study and a model simulation. In other words, there were 2 phases. The first phase was to go through this retrospective cohort, or cross-sectional study, I should say. And then from there, introduce a number of models or simulations to see what would have the greatest impact on the system. These are predictions that we make, obviously, as a result of some existing data. So as I mentioned, program of research, and this is phase 2. So this study took place in York Region, paramedic services. It occupies about 1.2 million people. They service that many people. Mixed density of rural, urban, not quite remote, but still a mixed density of populations. It includes residential, commercial, and industry in that area. Mix of demographics, of course. Has 3 regional hospitals within its borders, but transports patients to hospitals outside of those borders. Employs about 487 paramedics at the time of this study. About 35% or so, I think, are at the advanced care paramedic level, and some of these 487 are part-time. They operate between 26 and 36 ambulances in a 24-hour period across 21 stations, and all their data is electronic, all their EPCRs. So as a brief overview of the study, the way it looks is we looked at all the patients who had contacted 911 in a particular date range. It turned out we used a year. Those who were transported within the boundaries of those 3 regional hospitals. We looked at all their EPCRs. We randomly selected 3,000 from there. We looked at some primary outcomes, and then created a bunch of models. So in the patients that were transported, this is our inclusion-exclusion criteria. And so we were looking for residents, people who lived within the region, and that's an REB issue. People who were over the age of 18. They must have contacted or engaged the system through a 911 phone call, so they called for emergency services that they felt was an emergency. They were transported to one of the regional hospitals, and we used patients who were CTAS 2, 3, 4, or 5, and so this eliminates people who are in cardiac arrest or extreme situations. And then we must have been able to match their record to hospital record, and then we eliminated anybody who was an interfacility transport or anybody who was bypassed, and in this particular region there are a couple of bypass protocols like STEMI, for example. We stratified, or we took a sample of 3,000 patients, and from there we stratified based on the CTAS for the population. So you take all calls for the entire region for that year, You look at the distribution of CTAS. That creates your baseline, I guess, for how you're going to select your sample. So we did that by hospital and by CTAS overall. From those 3,000, we looked at a number of outcomes. For this particular phase, phase 2, I'll just highlight some of them. So admission or disposition, their most responsible diagnosis, their interventions and diagnostics. And then there were 15 other categories with a number of subcategories, but I'm just reporting these here for now. You take all that information, once you pull all that out, you take all that information and you dump it into some models, and you can create endless number of models by which to test and look for predictions in terms of impact on the system. So the first way, in terms of analyzing all this, the first thing we did was create a classification system. That system is basically picks up on interventions, diagnostics, admission status, and most responsible diagnosis. You allow patients to fall into those categories based on that information. And then you explore their interventions and diagnostics by group, and then establish an index, and that index comes from their frequency, the frequency within that 3,000 patients in that year, and their association with discharge from emerge. If you look at all that information together, and in the background, you're also exploring the most responsible diagnosis. And again, as a reminder, this is the idea, is we're trying to think about what can we shift, what kind of services can we shift, and what kind of pathways and communication can we have between these different organizations, these different settings, in order to improve capacity in the system. So as far as results, we whittled it down from 77 available records that met some inclusion criteria. After some cleaning, we eventually get down to the 3,000 randomized patients. We didn't have to do anything with the stratification, because pulling the 3,000 out randomly, as you would expect, aligns with the CTAS distribution in the same way, so we didn't have to do anything more. And of those 3,000 records, 1,660 had advanced care paramedics on that call. That'll become relevant here in a second. And this spanned across 23 communities in the region. I don't know the total off the top of my head, but that's a large span. So one of the things I'd like you to focus on is on this table, and this is specifically around groups 1, 2, 3, and 4. You'll notice that there are 10 categories, and this is a classification system only based on these variables. What you're not seeing here is the most responsible diagnosis, which is working in the background, and how it relates to ambulatory care sensitive conditions or not. So just based on that, you look at group 1, for example. So anybody who falls into group 1 would be people who didn't receive an intervention, didn't receive a diagnostic, and were not admitted. And then you can go down the list to group 2, which were interventions, none, diagnostics, yes, still not admitted. And so we believed, or argued, I guess, that I'd ask you to consider that those in the non-admitted group, that there's probably an opportunity there at least to consider some shifting of services, maybe, maybe not. And so we shouldn't assume that there is, but perhaps there might be. So these are the numbers. So you'll see there that 65% of the patients who call 911, call emergency services, get transported to emerge in this particular region, 65% of the time they never get admitted. So to us, that's like I said, just an opportunity for us to explore in terms of what can be done. And if you break that down a little further, you'll see that group 4 has 36% as the largest group, 36.4%. These are the patients that we would say are getting fixed in emerge. So being taken to emerge, they're getting some additional diagnostics and interventions. They're being fixed and then sent home. And then again, there's a large group of information underneath that we don't need at this point. So from this point forward, we're just focusing in on that 1954, so that 1,954 patients, and that's 65%. So you take all that information, and when we extracted the information, in particular the most responsible diagnosis, we used the ICD codes, and those of you who are familiar with that, you'll know that they are very, very granular codes, very, very specific at times. And so to take all that information, when it's that specific, I think we came up with 472, I believe it was, different diagnoses. There's a group of researchers in the US that have come up with ways for the purposes of analysis and reporting to group these conditions, these ICD codes. So what you're seeing here are essentially the groupings. So the first one, for example, where it says other injuries, conditions due to external causes, it might be opened up to trauma or injury to numerous parts of the body, heat-related injuries, allergens, foreign bodies, MVCs, etc. So all I want you to know is that when you look at those patient lists, is that there's a list of more detailed, granular information in terms of what types of patients are being seen. The other thing to look at is where it says discharge out of 2,927 patients meant that 70 patients were excluded for some reason, and that's the index of discharge. In other words, and what you'll see there is that no one's at 100%. In other words, even in these patient types, these are the highest out of all the ones that we looked at, but even in these patient types, nothing is 100%, which means there's a degree of risk if you're going to target these patients. So some of these patients are getting fixed or treated and emerge, and release. Some of these patients are getting admitted. And so you have to factor that in when you're trying to think of models that you're going to suggest for a service to consider. The index value on the far right is our simple ways of calculating the frequency of the event, the association with discharge. Put that together, it gives you some sort of index which you can rank. So when you look at the, I'll go through this one very quickly. When you look at the different patient types that we just looked at, then you can look at their group distribution. Basically what you can see there, just by looking at the bold and the pattern, is that the majority of these patients sit in group 4. In other words, they're getting fixed and emerged, treated, diagnostics, interventions, and released. So again, that suggests that there's a degree of risk that might come with trying to deal with these patients outside of that setting. So now when you start to create these models, and what I'm showing you here are 12 different models. I'm not, it's just, this could be 50 different models, and I'm just showing you 4 of them. And so the first one is this: if you looked purely at diagnostics, if you said what diagnostics are most frequent, most associated with discharge, most associated with those patient types that we just talked about, put all that together and say, okay, well, what diagnostics would we want to, or we think might be a reasonable strategy to put out to shift services. And so this is what you see, and when you put those diagnostics there, where it starts with CBC differential and all the way down, you see the percent change in number of patients to group 1. So you take all the patients that are spread off across those 4 groups, add these diagnostics to a system outside of, say, to a paramedic service as a model, and that shifts the number of patients that you can put into group 1, which potentially, because it's all simulated models, potentially may not need any additional services in an emerge. Now, the first pushback I always get when I say this, when we talk about this topic, is that you can't just give people diagnostics and expect them to work. And let me say that the caveat is, of course, that the diagnostics have to come with a degree of clinical reasoning. So it's not just purely diagnostics. But anyways, the percent change is significant. You can move up to 369% increase in the number of patients you move into group 1. If you do interventions, you'll see that the impact by according to interventions is not as great. It's only about, you're only essentially doubling it to some extent, and so the impact is not as strong, but still adds some information. And so there's a list of things that you can add in terms of shifting services that potentially, again, might result in some impact in the system in terms of capacity. When you combine the two, then you start to see the power of this whole thing. You see a change of 500%, over 500% change from the initial values, from the baseline values, by introducing these diagnostics and interventions into a 911 system, into an emergency system. The important point to look at, too, is up at the top there where it says even the increase from simple baseline to increasing what would be included in our system, the advanced care paramedic scope of practice, just by factoring that in a little bit more, in other words, encouraging people to use it more and not transport patients or treat them outside, increases it by 35%, which tells you that there's a little bit of opportunity happening there. Take all that information and you look specifically at patient types now, and I'm only presenting 3 of them here. But if you look at all that information, you look at number 1, 2, and abdominal pain was number 4 or 5 in terms of ranking. You see that you can have a significant impact on patient type number 1, significant impact on patient type number 2, which is non-specific chest pains, but the abdo pains don't get affected by these models. In other words, the things that come out on top in terms of interventions and diagnostics don't affect this patient group in particular. So what that means is you can focus in on interventions and diagnostics, or you can focus in on patient types in terms of if you were trying to build a model or build a system to deal with this issue, you could target it in either way. You have both options. So again, the idea was, how can we have an impact on this issue of people who need services, an increasing need in services based on a growing and aging population, and availability of services. And the idea is, can you shift services? And that's what we were thinking. And so we were interested in whether or not we can put these services into a paramedic service model and then start to contribute to this integration or begin to work towards this integration as a part of a program of study. So what we get from this portion of the data that I've shared with you is that at the very least there's opportunity here. And I think everyone knows that. I think everyone in this room certainly knows that. There's opportunity. And if you extrapolate that 65% to this particular region's population in terms of call volume, then you can potentially affect up to 35,000 patients. While that sounds impressive, it's hard to determine the accuracy of that number, so it might be an over or underestimation, we don't know. But you start to get a sense of how much you can affect the entire system. The other caveat I'll put in here is now there's a degree of risk. When you introduce these interventions and diagnostics, or when you target this patient population more so than we're doing today, there's a degree of risk associated with that. Those values suggest that. So because they're not 100%, it's telling you that there's a degree of risk associated with that, although you can make judgment calls about how much risk is associated with that. It's just something that you have to consider going forward. And as I said earlier, interventions and diagnostics alone are insufficient, and so there's the caveat being that there's the appropriate degree of clinical reasoning that goes along with introducing these services in a model. The other thing we take away from this data, just looking at it quickly, and I know we've gone through that data very quickly, is that diagnostics matter most, it seems. It seems this rule-out idea or this rule-out process seems to have the biggest impact on what potentially could go into Group 1. In other words, not needing any additional services in a merge. And so interventions have less of an impact, but when you start to put that together, you start to really see the power of it. The only thing to consider is as you add things, training costs and CMEs and so on start to go up as the complexity of the case becomes bigger. The other thing I just want to point out quickly is when we were doing this work, we took off our never hat, if you will. We decided that there was just going to be no limitations in what would go on in terms of the interventions and diagnostics. If they made it to the top of the list, they went in. We did make some feasibility analyses to say what would be feasible, what wouldn't be feasible, and consider that in some of the models. But this really is aspirational in terms of looking forward and saying, where can we go potentially? The other thing is patient types matter. So as I said earlier, some patient types are not affected by these interventions and diagnostics that sort of bubble to the top. And so you might want to focus there or focus in on patient types specifically. For example, some have minimal impact like abdo pain, some are very significant. The other thing we notice is that there's a large number of patients that get transported who obviously don't need to be, and in our system there's somewhat of an obligation to do that, to transport these patients. So there's a cultural issue here that would be difficult to quantify, and so it might be something that we'll have to think about in terms of shifting that culture, that thinking of transporting everyone kind of thing. And as I mentioned earlier, the ACP skill set alone can have a significant impact. Now in this particular study, there are of course some limitations. As I mentioned, it's an aspirational simulation type model. You can't predict these things with 100% certainty, and so please keep that in mind. And so it's isolated to one region. There are multiple models possible. All I showed you was 12. I spoke about 4, but there's 50 or 60 that we've gone through, and so these tend to be the ones that have the largest quote-unquote impact. As I mentioned, these are simulations, and we did have to consider to some extent the feasibility limitations that would be present in doing this type of work. So in conclusion, I would say so far where we're at, and this is all preliminary data at this point, so far where we're at is that there is an opportunity. We believe that there is an opportunity, and that the consumption of healthcare, at least in this particular region, I would suspect this exists everywhere, is not expected to decline. It's expected to climb, obviously. And so the idea is, can we build capacity by shifting or adding services in the system through that model that's presented up there? So what can we shift to other settings? And we would argue that at the moment, based on what we're seeing so far, there's the potential at least for a very underserved population, at least in our system, when it comes to dealing with these types of events, these patient events in terms of contacting 911. All we've talked about is really that side of that triangle, the potential of integrating paramedic services more with emergency departments. And this is not necessarily, I'm not necessarily suggesting that you shift services entirely from emergency departments to pre-hospital settings, although that is part of what we are saying, that this interaction between these two departments is probably the best way to go. And so integrating services is very important. And that we would argue that we're contributing to the problem currently, and so at the very least we have to find ways of of stopping that and not contributing any further and trying to mitigate this tension that I talked about earlier at a healthcare system level as opposed to just the paramedic service level, at least in our setting. The last thing I'll say is we didn't discuss any of the ambulatory care sensitive conditions, and so the other part of this analysis includes looking at all those most responsible diagnoses, looking at how they align with or not ambulatory care sensitive conditions, and whether or not we can work on the bottom part of that triangle with primary care and ambulatory care and see what can be managed there. And a lot of the work that you're doing that I heard yesterday targets that part there. You're working with ambulatory care and primary care to some extent in many different ways, but that targets that bottom part of the triangle, and this particular talk just talked about that side of the triangle up at the top between emergency service and paramedic services. I don't know how much time we have, but I'd really like you to push back on this. If you believe that there's something here that sounds crazy or inappropriate, we'd really like to get some pushback so that we can think more critically about what we're thinking about with this work. That's it. Thank you.